Good morning, everyone. Thank you so much for joining us today. My name is Dr. Bhavana Konda, and I am a neuroendocrine tumor expert and medical oncologist at the Ohio State University Comprehensive Cancer Center. I'd like to begin by expressing my gratitude to the Neuroendocrine Cancer Foundation for inviting me to speak with you. It's truly an honor to be part of this important conference. My topic today is an essential one. What is neuroendocrine cancer? Whether you are a newly diagnosed patient, supporting a loved one, or just looking to understand more, my goal today is to help make this complex condition a little less overwhelming. Here are my disclosures. A question that I get asked a lot: is this a cancer? And yes, neuroendocrine tumors are cancers. These are rare cancers that arise from abnormal growth and spread of neuroendocrine cells. Neuroendocrine cells are present in all of us in several parts of our body. These cells produce hormones in response to signals from the nervous system, hence the name neuroendocrine. When these cells start to grow and spread abnormally, they form a neuroendocrine cancer. Now, there are some rare exceptions. For example, pheochromocytomas, which are tumors that arise from neuroendocrine cells in the adrenal gland, and paragangliomas, which are closely related to pheochromocytomas but arise outside the adrenal gland, can be benign or cancerous. Leaving out these rare exceptions, neuroendocrine tumors are, for all practical purposes, cancers. It's important to understand that all neuroendocrine cancers are not the same. These are a spectrum of cancers, as you can see here, ranging from slow growing on the left to rapidly growing aggressive cancers on the right. Let's take a few minutes to go over some of the terms you might hear when learning about this disease. Knowing these terms can make it easier to understand what the disease is and how it behaves. First is origin. That is, what part of the body did the tumor first begin? For example, if the cancer started in the lungs, it's called a lung neuroendocrine cancer. If it started in the stomach, it's called a gastric neuroendocrine cancer, and so on, as you can see here. Second is stage. Has the tumor spread out of where it started from? And if so, how far has it spread? If the tumor is present only in the place where it began, we call it localized, as shown here in this picture. You see that the tumor is localized to the pancreas here. If it has spread to nearby tissues or lymph nodes in blue here, we call it locally advanced. If it has spread out of where it started from to distant parts of the body, we call it distant metastatic or stage 4 disease. At the bottom, you see that the pancreatic neuroendocrine tumor has spread not only to lymph nodes, but also to a distant location like the liver. You see all these tumors in the liver. So this is considered stage 4 disease. Next is tumor differentiation. This is described in pathology reports as well differentiated or poorly differentiated. What does this mean? When pathologists examine a tumor under the microscope, they look at how closely the tumor resembles normal cells. This is called tumor differentiation. Normal cells are depicted in the top panel here. Well differentiated neuroendocrine tumors, or NETs, on the left look more like normal cells. These cells tend to grow and spread more slowly. Poorly differentiated neuroendocrine carcinomas, or NECs, on the right here look very different from normal cells. These are aggressive and grow rapidly. Understanding the stage and differentiation of a tumor helps guide several aspects of your cancer care. It helps clarify goals of treatment. Is our goal to cure the cancer, to control it, or to relieve symptoms? For example, an early stage well differentiated neuroendocrine tumor might be curable with surgery alone. A more advanced or aggressive tumor might need a combination of treatments. It helps your doctor tailor treatment specifically for you, as there is no one size fits all approach to treatment here. It helps determine prognosis. Prognosis means the likely course of your disease, that is, how it might behave over time. Well differentiated early stage tumors have a better prognosis than poorly differentiated or advanced stage cancers. It helps plan follow up intervals. That is, how often do we need to check in with scans or blood work? A slow growing, well differentiated neuroendocrine tumor that has been surgically removed may need monitoring only every 6 months. A faster growing tumor would need more frequent follow up. Let's talk about Ki67. Ki67, or proliferation index of the tumor, is a marker we use to understand how fast a tumor is growing. It's a protein found only in cells that are actively dividing. When the pathologist calculates the Ki67, he's looking at what percentage of cells in a tumor are actively dividing. For example, a Ki67 of 3% means that 3 out of 100 cells are actively dividing. If Ki67 is 20%, that means 20 out of 100 cells are actively dividing. Why does this matter? The higher the Ki67 percentage, the more aggressive the tumor. We use Ki67 to help assign a grade to neuroendocrine tumors that originate in the GI tract or pancreas. Grade 1 neuroendocrine tumors have a Ki67 less than 3% and tend to be slow growing. Grade 2 neuroendocrine tumors have a Ki67 in the range of 3 to 20%. These are intermediate in aggressiveness. And the high grade or grade 3 neuroendocrine tumors have a Ki67 over 20% to 100%, and these are more aggressive. Another important marker to understand how aggressive a tumor may be is the mitotic rate. This is measured by the pathologist, who looks at the tumor under a microscope and counts how many cells are in the process of dividing. Why is this important? The higher the mitotic rate, the more aggressive the tumor. Like Ki67, we use mitotic rate to assign grade to a neuroendocrine tumor. Again, grade 1 have a mitotic rate less than 2 per 2 millimeter square. Grade 2 have a mitotic rate intermediate, 2 to 20. Grade 3 have a mitotic rate over 20 per 2 millimeter square. Mitotic count helps us understand how fast the tumor is likely to grow and how we might need to treat it. Another important term to be familiar with is tumor heterogeneity. Tumor heterogeneity means that not all neuroendocrine tumors are the same. Two people with the same type of neuroendocrine tumor may have different tumor grades. Even within one person, the primary tumor and a metastatic tumor can have different grades. In this picture here, this patient's primary tumor is in the pancreas and is grade 1, and the lymph nodes it has spread to are grade 2. Sometimes, even within a single tumor, there can be two different grades. As you can see here in this picture on the left, a portion of this patient's tumor that has spread to the liver is grade 1, and the other portion of the same tumor is grade 2. So while markers like Ki67 and mitotic count give us valuable information, they're ultimately just tools to help guide us. Since it's not practical to biopsy every single tumor in the body, it's crucial to look at how the tumor is behaving over time, especially on imaging, to understand how quickly it's growing and how best to treat it. Putting it all together, here is how neuroendocrine cancers that start in the GI tract or the pancreas are classified. Based on tumor differentiation, we have well differentiated NETs and poorly differentiated NECs or neuroendocrine carcinomas. We talked about grading in the previous slides and how we use Ki67 and mitosis to assign grade. The higher the grade, the more aggressive the tumor. Well differentiated neuroendocrine tumors are variably aggressive, but many of them are relatively slow growing with a natural history that can evolve over many years. In contrast, poorly differentiated neuroendocrine cancers are uniformly highly aggressive and grow rapidly. This is a classification for lung and thymic neuroendocrine cancers. Again, we have well differentiated NETs and poorly differentiated NECs. The subcategories are a little different here. Well differentiated neuroendocrine tumors are divided into two main types: typical carcinoid and atypical carcinoid, and this is based on the number of mitosis and whether there is necrosis under the microscope. Necrosis is basically death of cells within a tumor, which is a sign of the tumor growing quickly. Typical carcinoid tumors have no necrosis and have very few mitosis. These are usually slow growing tumors. Atypical carcinoid tumors, on the other hand, have necrosis or a high number of mitosis, making them faster growing. Now, when you look at poorly differentiated neuroendocrine cancers on the far right, these have a lot of necrosis and a very high number of mitosis, making them highly aggressive cancers. Many patients with neuroendocrine tumors have no symptoms, and the tumors are discovered incidentally during imaging or procedures for unrelated issues. This is especially common in early stage or low grade tumors. There are others who may have symptoms. Symptoms could be due to hormone production by the tumor, which is called carcinoid syndrome, which can manifest with diarrhea, flushing, racing of the heart, which are called palpitations, wheezing, or lightheadedness. Symptoms can also be due to the tumor itself, causing abdominal pain, bloating, weight loss, decreased appetite, fatigue, and so on. What can you expect? At your first clinic appointment with a neuroendocrine tumor expert, your doctor will go over the results of your blood work and scans with you and explain what they mean. You will also learn more about the origin, differentiation, grade, and stage of your tumor. Your doctor will discuss the goals of treatment, whether that's curing the cancer, keeping it under control, or helping you feel better. You will gain a thorough understanding of what lies ahead in your treatment journey. Depending on your specific needs, your doctor may refer you to other specialists such as a surgical oncologist, a gastroenterologist, or a GI doctor, or an interventional radiologist. These experts would become an integral part of your care team and will work closely together to come up with the best treatment plan for you. Your case is also reviewed in a multidisciplinary neuroendocrine tumor board. The board comprises of several experts, including medical oncologists, surgical oncologists, radiologists, radiation oncologists, pathologists, and many more. They review your case and provide recommendations on the best course of action. These discussions may happen multiple times during your treatment journey. If you have disease that is localized or locally advanced and resectable, typically resection is pursued as it's curative. If the tumor is not resectable, or you have stage 4, particularly low grade neuroendocrine tumor, no symptoms, and a small amount of disease, your medical oncologist will often recommend watchful waiting to assess the pace of growth of your cancer. It's important to remember that unlike other cancers, many patients with stage 4 neuroendocrine tumors live for several years. While several treatment options exist today, they're not unlimited and not without potential side effects. So we have to use our treatments wisely. You and your team of doctors will make treatment decisions together. Always ask about clinical trials and what clinical trials might be options for you. Poorly differentiated neuroendocrine cancer, on the other hand, is a very aggressive cancer, and treatment usually begins as soon as possible. Your doctor will also talk about sending your tumor for next generation sequencing, where your previously biopsied tumor specimen will be sent off for analyses to look for abnormalities to help guide treatment. Treatment options remain quite limited in these patients, and we continue to work on developing clinical trials for this aggressive disease. As we wrap up, I want to leave you with a few takeaways. First, neuroendocrine tumors are cancers. These tumors are heterogeneous. That is, not all neuroendocrine tumors are the same. They vary a lot in their behavior from one person to another and even within the same person. Tumor stage tells us whether the tumor is still in one place or has spread out of where it started from. Tumor grade and differentiation are prognostic. That is, they help predict how your tumor will behave over time, how fast it may grow, and how likely it is to spread. Well differentiated low grade neuroendocrine tumors tend to be slow growing. Poorly differentiated neuroendocrine cancers and high grade neuroendocrine tumors, on the other hand, are very aggressive and grow rapidly. Treatment of these rare cancers requires a multidisciplinary team of neuroendocrine tumor experts. Finally, knowledge is power, especially when facing a diagnosis like neuroendocrine cancer. By educating yourself about your cancer, you become an active partner in your care. You are not alone, and we are here to support you every step of the way. Thank you for your attention.